Hi, I'm Kendra, and this is my third visit for chemotherapy to treat my breast cancer. There are obvious genetic factors associated with breast cancer. That's why it wasn't all new to me, but it doesn't make the process any easier. Being in and out of hospital affects every aspect of my life and has really taken a toll on me mentally and physically. My doctor has informed me about new treatments that work to increase the number of healthy cancer-fighting cells, which is something that I'm very interested in for myself and the future generations of my family.
Hi everyone, I'm Kendra's doctor, Dr. Ryan. To elaborate on what Kendra has said, there are several new treatments being researched to replace the chemotherapy. The major side effects of chemotherapy are lethargy, weakness and loss of hair in some patients. Due to low numbers of healthy T cells in cancer patients, what we call checkpoint inhibition is currently under the microscope as a new method of fighting cancer. Immune checkpoint inhibition occurs in the immune response. In the normal immune response, the immune system is activated, turning T cells on to attack pathogens and turned off when the pathogens are no longer present. In cancer, the cancerous cells turn off the T cells when they attach to specific T cell receptors. Immune checkpoint inhibitor drugs prevent the cancer cell from attaching to the T cells, so the T cells stay activated, preventing the cancer's growth. Now let's look at the mechanism of immune checkpoint inhibitor drugs.
Firstly, all cells have an area called the major histocompatibility complex, or MHC, where an antigen for that specific cell is attached. In tumours, a cancer antigen that attaches to the MHC is recognised as foreign. This is a red flag. This first step is termed MHC recognition. Now, in antigen-presenting cells, APCs, the MHC will recognise the cell membrane and present the correct antigen to the T cells. The T cell receptor, TCR, binds to the MHC of the APC, but then requires a second step for activation, which involves the binding of the CD28 receptor of the T cell to the B7 ligand of the APC. This completes the activation. To ensure that the T cell is not overexpressed or permanently activated, upregulation of cytotoxic T lymphocyte-associated protein 4, CTLA-4, occurs on the cell's membrane. This affects the initial activation because CTLA-4 has a higher binding affinity for the B7 ligand on the APC. Therefore, the B7-CD28 receptor interaction is overridden. CTLA-4 bound to the B7 ligand inhibits the synthesis of interleukin-2, therefore causing inactivation. This is where the drugs of interest come into play. Inactivation of T cells is detrimental to our immune system as they are our first line of innate defense. CTLA-4 plays a key role in inactivation. Therefore, blocking the action of CTLA-4 would allow the T cells to remain active. Ipilimumab inhibits the CTLA-4 receptor, resulting in the inability to bind to the B7 ligand on the APC. T cells present many different inhibitory receptors on their membrane. Therefore, if a different ligand, PDL1, is present on the APC, it will bind to another upregulated T cell membrane receptor, programmed cell death 1 receptor, or PD1. This interaction also causes inactivation of the T cell. The drug pembrolizumab can inhibit the PD1 receptor, thus the T cell remains activated. If both PD1 and CTLA-4 are upregulated in T cells, we could effectively use both drugs to target their respective receptors. This is termed combination immunotherapy. Recent studies have suggested that this is even more effective than a single checkpoint inhibitor drug. Nivolumab has a similar mechanism of action to pembrolizumab, as it is also used to block the PD1 receptor. Now onto efficacies. All three mentioned drugs are administered intravenously and their therapeutic target are the cancer-causing APCs in the bloodstream. This route of administration allows for 100% bioavailability. In separate Phase 2 trials to treat patients with advanced melanoma, the three drugs of interest were tested. In the pembrolizumab trial, there was a 32 to 33% response. In the ipilimumab trial, there was a 27% response. In the nivolumab trial, there was a 31% response. This shows that PD1 checkpoint inhibitors are slightly more effective as the receptor has a higher affinity for the compatible drugs, pembrolizumab and nivolumab.
Now let's move on to toxicities. Although these drugs currently have been approved and have shown that they've been quite beneficial and effective in treating cancer, they do however can cause common possible side effects. Side effects of fatigue, rashes, fevers, diarrhea, and hypertension usually occur. They may also cause immune-related adverse events due to immunological enhancements, where these are usually more severe dermatological, gastrointestinal, hepatic, and endocrine side effects, with other less common inflammatory events. PD-1 inhibitor drugs, pembrolizumab and nivolumab, are known to cause these immune-related adverse events, although they are less in severity in comparison to the CTLA-4 inhibitor ipilimumab. But not to worry, we are able to treat these adverse events by using immunosuppressive corticosteroids. There are different levels of severities of immune-related adverse events, and depending on the grade, we administrate the appropriate level of immunosuppressive drugs. Patients suffering from grade 2 adverse events should cease checkpoint inhibiting treatments at once, until it has been reduced to grade 1 or less. While it's still suffering from grade 3 to 4 immune-related adverse events, the treatment with checkpoint inhibitors should be permanently discontinued, as this is quite severe and life-threatening. Do keep in mind, however, there are other possible immunosuppressive treatments which we can use, those including the tumor necrosis factor alpha antagonists and the mycophenolic acids. And now, let's move on to future directions.
Future developments in the field of cancer treatment would include the following. Firstly, predictive biomarkers, because they have become the more widespread therapy use as they improve patient selection, maximize benefits, minimize risks, and help clarify treatment to specify anti-PD-1 and anti-PD-L1. Secondly, elimination of the toxicities and increasing the efficacies of treatment through continuing research and clinical trials. And lastly, development of the new immunotherapy drugs such as cancer vaccines that target the tumour cells and depend on the circumstances of the individual patients.
Thanks for tuning in, guys. If you want to know more about immunotherapy, click here.